Hi, everyone. Welcome to week 4 here in healthcare management and marketing for Access. I hope everyone's having a good week. I know it is beautiful weather we're having, and it looks like it's going to stay that way for a couple of days. So I hope everyone is doing well. I just want to say thank you for the efforts that you've put out so far in this class. We're in week 4 already. Time really flies when I'm teaching a class. So at this point, I hope you feel you are gaining a greater understanding of the manager's role here in the business of healthcare. I know that this is a relatively high overview of what a manager does and all the different aspects of management in healthcare, but it provides you an idea of the what did I want to say? The type of duties and responsibilities that a manager faces when they work for a healthcare institution. And if any of you have worked in another business other than healthcare in the past, you will definitely see the difference between an example in a retail business or a restaurant compared to what we have to deal with in healthcare. So quick little bit of housekeeping. There's no assignment this week, as you saw in the unit, but there is just the one forum, and it involves the case of Mrs. Bell. But I do want to remind you about the group project. You should be working on the group project together. It's not due, the first part is not due this week, but it's due the following week. I also sent out an email about the dates for all the upcoming assignments. When I changed them, I unfortunately forgot to change them in some places. So yesterday I went through and made sure everything was consistent. So please continue to work on that group project. And if you have any questions about the group project or anything else, please be sure to get in touch with me. You can email me at the sales email. If it's something urgent, the best thing to do would be to text me because I'll get that right away, and then I can check email, or we can talk on the phone or whatever. Don't have any problem talking to you on the phone. Okay. All right. So this week I'm going to review chapter 7 and 8. Excuse me while I pull my text over here. Chapter 7 is quality and performance improvement basics. I'm sorry, I have to keep this mouse out of the way here. And chapter 8 is health informatics and health information systems. I'm going to spend the majority of the time on quality and performance improvement basics because it's such an important component in healthcare. Health information systems, I know most of you are already familiar with, so I'm only going to talk about, just give you a couple of thoughts on that. And I definitely want you to read the chapter, but don't get yourself all wound up in the different things that they have there, because I know you've all had experience and it's kind of a repeat. Okay, so let's define quality in healthcare. Healthcare quality can be defined in various ways from differing viewpoints of healthcare providers, patients, third-party payers, policymakers, and other stakeholders. So the way a patient views healthcare quality is very different from the way a third-party payer does, or sometimes even a physician for that matter. There are a lot of people that know absolutely nothing about healthcare. And I think as those of us who work in healthcare, we tend to forget that most people don't know very much about their own healthcare, let alone the business of healthcare in general. What they know is if they need care, they go somewhere where they're going to get care, their insurance pays for it, or maybe they don't have insurance, unfortunately, but one way or another, they're going to receive care. They may know very little about preventative care, even understanding their own medication. Well, for example, a person in my area posted on a local Facebook page, a town Facebook page, that she was looking for an eye doctor, an ophthalmologist, an MD. we live in a very rural area, and the closest hospital to here is 35 minutes away. There's two others, but they're both over 45 minutes away. So pretty much it's understandable that the physicians who are affiliated with those places are closer to the hospitals and other healthcare facilities than they are in a rural area, specifically a specialist. And this person was looking for an ophthalmologist within 15 minutes uptown of where she lives, which is just kind of goes to show you how uninformed and how many people just don't understand healthcare, and even where they can access it, and what it entails, and then that doesn't even touch on the clinical side of healthcare and how many people have a healthcare problem. They get treatment, they go home with particular medication, and they don't understand it, and they're not compliant. So it's a very complex business. And when it comes to quality, patients are definitely going to look at it in a very different way than providers and the list of people here that I mentioned. In clinical and non-clinical healthcare, what's important and what is ideal will vary depending on the perspective of the stakeholder. If we talk about hospital care, patients are mostly concerned with the food and whether they get their tests on time and when they're going home. In general, I mean, clearly they want to have good care. They want to go in alive and come out better than when they went in. But their perspective is completely different, again, from the provider. So from the perspective of different people, people look at it differently. Another way to define quality is a system with interdependent parts that have to work together. And they work together so that they achieve outcomes. It doesn't say positive or negative, but it says outcomes. In 1966, a man by Avidis Donabedian defined quality in terms of structure, process, and outcome. What's important about this is that he was able to look at the delivery of healthcare, which is very complex, and put a set of parameters around it to help us determine what is the best structure, process, and how do we get a good outcome. And this chapter goes into various aspects of that. The structural elements of quality involve material and human resources in an organization and the facility. So that's the structural. Simply put, the process involves the actual delivery of care as well as the management of care. And the quality of basic care, which includes things like cleanliness, the food quality. And the text here mentions hydration. In other words, do you have enough fluids? You get enough things to drink. The delivery of the treatment and keeping patients safe from falls, which is very important in a hospital and any other healthcare environment, outpatient facilities, doctors' offices, etc. Outcome is the resulting health status of the patient, regardless of their length of stay, what facility they're going to, that sort of thing. Outcomes are something that we've looked at, and it's, as I said, this person developed this in 1966. Outcomes are something that we've looked at for many, many, many years. Donabedian also looked at something we call best practices. Trying to think of the other word for it. I'll mention it later in the lecture, but there's another name for, evidence-based medicine is something that we look at that's similar to best practices, but it's a more modern version of the same. So the best practices is the ideal to which an organization can aspire to improve care. So you take a general overview of what you see everybody else doing, what their outcomes are, and yet from that you pull what appears to be the best practices. So it links all three of those things we just talked about: structure, process, and outcome. This Donna Beatty also defined quality as having 4 components, which I'm going to review very briefly here. The first one is the technical management of health and illness, which is the clinical performance of the healthcare providers, how they provide you the care. The second thing is the management of the interpersonal relationships between the providers of care and their clients or patients. How do they communicate? The text calls it the co-production of care by both the providers and the patients. In other words, the encounter level, health service at the patient provider encounter level, health service quality is driven by both the clinical and the non-clinical process. That's sort of a complicated way of saying bedside manner. How does the relationship with the provider affect the patient or the patient's family? And clearly that is extremely important so that you do have a positive outcome from the healthcare that you provide. In today's world, there is many of us who believe that we as individuals need what you call a healthcare advocate. If you end up having a complex problem or unfortunately an admission to a hospital for a problem, things are so complicated today in healthcare that it's really best to have someone that's with you, that goes with you, to listen to what the practitioners say, try to understand the kinds of tests and things that you have to have done so that you have a better understanding of what the process is going to be, and so that you have a better understanding of how you, once it's over, how you take care of yourself. There are people that are employed by hospitals, they're called nurse navigators, that will help patients through that. But in general, it's always best to have someone from your family or friend that goes with you to help you understand these things. So the interpersonal relationships is very key in the quality process and the outcome. The third thing is the amenities of care. And those are the kinds of things we would look for even if we went on vacation. Is it comfortable and clean surroundings that the facility is? And that includes doctor's offices. I know many doctor's offices today are very clean, modernized, but there's still a few out there that have been around for a while and they still have that old dark paneling and old carpets and uncomfortable furniture. And as patients, sometimes we look at that and say, I wonder if the provider is too old to take care of me or is outdated. That's probably the word I should use, because of the surroundings that we see. Okay, and the last part is ethical principles, which speak to the provider's ethical conduct when they deliver care. We've heard many, many scary stories of people being abused in a physician's office or things like that. Clearly, that's unethical and illegal conduct. But it happens, and it's something that healthcare providers and healthcare facilities do most of the time and should see as a very important part of their healthcare delivery. There's two things that that Donna Beatty mentions that kind of summarize things, and they are a more focused view of quality represents two fundamental questions about clinical services. The first one is, are the right things done? And the second one is, are things done right? So did you pick the appropriate treatment? And then was that treatment delivered correctly? The first question assesses effectiveness, and the second question assesses efficiency of care. So as you learn more and more about quality improvement and quality ongoing projects, you're going to hear a lot about efficiency and effectiveness of care in a variety of different ways. Another thing that best practices include are the patient and the population served as part of the healthcare team. Effectiveness in this area is defined as providing services based on scientific knowledge to all who could benefit, and refraining from providing services that do not likely benefit the patient. You may be underusing it or overusing it, one or the other. And efficiency is defined as avoiding waste, in particular, waste of equipment, supplies, ideas, and energy. And clearly, this has to do with the cost of care. So a big focus of quality improvement is decreasing costs, providing the most efficient and effective care at the lowest cost possible. So we're on page 139 here, and now we're moving to why is clinical quality management so important? It's because, as I just mentioned, it is the most important is to focus on the appropriate use of limited resources to improve the health of both individuals and the entire population. Efficiency and effectiveness hinge on ethical stewardship of resources and problems in the domain that can take three different forms: underuse, overuse, and misuse. So again, we're looking to make sure that patients are provided the most efficient and effective care without overusing products and services that don't need to be used, underusing what we call this best practices. This is very interesting fact that I did not know. Best practices take a long time to actually be utilized by physicians and facilities. And this is from personal experience. This doesn't say this in the text, but what my experience has been with best practices and how and why they take so long to be actually utilized is because providers and practitioners are often skeptical of new things, new drugs, new electronic health records, and new technology. And rightly so, because they spent many years in medical school. They spent many years in school in general, some of them 9, 10, 11, 12 years in school to get where they are. They learn the most effective treatment when they're in school. Now and maybe now they're 20 years into practice. They have all this experience behind them, and they're good at what they do because not only do they have this experience, but they have a sense of what works and what doesn't work for patients. So when you start to introduce best practices, and they include things like using the cheapest medication, the cheapest antibiotic, or not doing an MRI if you can do a CAT scan, and you're used to seeing an MRI because you know that that's the one that gets you the most information, it's hard for them to adapt it, not only because they want to do the best thing for the patient, but they also don't want to have a poor outcome. And unfortunately, we have a litigious society, and they don't want to be sued. So, and most of the people I know, that's not the first thing on their mind. However, it is something that they need to consider. So the text says that one of the studies they did on underuse of best practices says it takes an average of 17 years to actually reach clinical practices. And even when these practices reach clinicians, evidence-based recommended treatments may not be consistently used. So one of the issues with quality management is that best practices are underused. Overuse is a quality problem, as certain treatments are provided despite evidence of best practices that the treatment is ineffective. And they give the example of antibiotics being overused. Someone has a cold and the provider gives them an antibiotic with the thought that they're really sick, and so they don't get a bacterial infection, or so they don't get any sicker, we'll give them an antibiotic. But there is some data now that says that overuse of antibiotics causes resistance and other forms of problems. So that's an overuse. And then let's see, misuse. Misuse is mostly to do with patient safety, which is obviously a big deal. Medication errors, as they're talking about, they're just talking about medical errors in general, but medication errors are obviously unfortunate, but they do happen. So misuse is the other indication of quality. And these are the things that are quality indicators that'll be looked at. A next topic that I want to review with you in this text is quality of healthcare and patient-centered care. This is something we're starting to see. It's an emerging interest for patient populations. It's a theory that if we center care around the patient and around the individual, and it's responsive, and the care includes not only for their physical abilities and their medical needs, but it also includes things like social and psychological needs, transportation. Let's see, what's the other? So this one just lists social and psychological, but that does include transportation, family involvement. Patient-centered care looks at the patient as a whole. So it's not just talking about their, here's the medication you need to take. This will help your congestive heart failure. What they want to look at is their surroundings. What they will look at is their surroundings at home, their social and psychological abilities, who is there to help them, whether the place they live in is appropriate for them, or can they not even get around in their own home, that kind of thing. So it's patient or person-centered care, as it mentions. And the benefits of patient or person-centered care is that not only engages the patient in the decision-making process, but it leads to a better quality of life for the patient and hopefully better health outcomes. It does involve many providers, as you can tell from the different specialties that I mentioned there, but it also requires a strong coordination of those healthcare providers. So today's healthcare manager needs to be aware of this opportunity to enhance the delivery of healthcare. We see them in urban areas. I'm trying to think of it. It's mentioned later, so I will mention it to you. I will mention it to you later, but it has to do with federal funding, and where there are a lot of public concentration that need healthcare in one place. So we will see more of that, and there are going to be many opportunities to enhance the delivery of healthcare while these patient-centered homes are being implemented. Okay, the next part of the text is about the leaders of quality improvement, and I'm not going to review that for you, but I am going to talk about the complex nature of healthcare and why we need quality improvement. I'm sure that you can, excuse me, I think my allergies are somehow deciding to rear their ugly head. I think you, since you're in healthcare, most of you do understand already how complex this business is. Again, because we work with human beings. We don't just work with objects, retail, things that we need to everyday life, like cups and silverware. We work with human beings who are all individual and all very different, as is every provider. So complexity science shows us that healthcare is provided by essentially different independent systems. We have physicians and nurses operating in systems and are supported by other independent agents like emergency medical technicians. They bring patients to the hospital in emergency, aides, technicians, billing clerks, all kinds of different support systems. And the text gives a great example. If you think of these different people as museums in an orchestra, you had the clarinets, the oboes, the drums, the trumpets, the brass, the woodwinds, all that sort of thing. The healthcare manager is the conductor that points to and calls on professionals to come in at appropriate time to create optimal patient outcomes. So a manager stands in front of the group and helps make sure and identifies those that need to be involved and those that don't need to be involved. So it's very complex. The nature of healthcare is very complex. And managers need to develop appropriate responses in constantly evolving situations. Some of the things that a manager has to consider, according to the text, are managing paradoxes, as they say, the following competing values that the following competing values that the text is going to list here. And note, it says, note that there is an and, not an or in between the words. So efficiency and effectiveness, as I mentioned earlier, task-oriented and relationships. That's part of our list that we looked at earlier. And the last one is stability and change. These things happen together in an organization. They must happen together. Change, stability and change, efficiency and effectiveness, and task-oriented and relationships. So you have things that you have to do, but you also have to have a good relationship and a good rapport, not only with one another as providers, but with the patient also. So to best manage, it requires a mix of traditional management and some application of what they call complexity principles, which are those things that we just mentioned. And it's not easy. However, the thing that is most fascinating to me, and have been in the business for a long time, is that you have the opportunity to work in teams all the time. As a manager of one department, you aren't going to be alone, because there's a manager of another department similar to yours that's in the same boat. And together you can work to improve outcomes. Let's give an example. Let's start at the registration desk in a hospital or an outpatient clinic. You have to, as a patient, you have to walk in the door and register. Then you go to, let's say you're going to get outpatient services, lab, blood work, or x-rays. The outpatient system has to be coordinated with the lab and the x-ray department to let them know that the patients are here. And then that has to be, most places now don't do appointments. So there's a time frame that there's a quality performance measurement of wait time and time frame to be taken back as a patient, and then your x-ray being completed, and then your return back to the well, you don't usually have to go back to the outpatient, but you do it when you're done and you come out. So there's always a measurement of the time from the time you get there to you actually see the registration person, till you actually get back to the x-ray department, till you have the x-ray, until you're done and walking out of the facility. So there are all kinds of things that managers will be looking at in terms of quality and process, and they have the opportunity to work with other department managers. And the same goes for nurses on the floor. There's a nurse manager. She has the opportunity to work with other nurse managers and with the physicians and with the people that provide the other services, like who draws the blood, who brings the food, all those things. But it's almost always done as a team. So as a manager, you're usually not out there in a boat all by yourself. There's other people that are there to help you. And together you identify issues, opportunities, and methods to fix them or improve them, add things, etc. So what are some common elements of quality improvement? Well, what text looks, I'm going to look at just a couple of things. First one is performance monitoring and assessment. Measurement is the next one. And I'm not going to look at process validation. Okay, so just those two things we're going to look at. Performance monitoring and assessment are activities that are embedded throughout healthcare. I just mentioned the process of the outpatient, going to outpatient for a lab. That's the process throughout the healthcare experience. These measures and reporting are usually determined by corporate reporting requirements and sometimes government reporting requirements. They want specific data on patient care. There are many standards that require unplanned events, such as an adverse event, something significant, a patient fall, an adverse event from a medication error. These reporting activities focus on but aren't limited to things like healthcare associated infections. We used to call those nosocomial infections. medication use, blood and blood products, restraints, invasive procedures, and CPR. These are some of the standards that are looked at, and generally those are the top few. Healthcare managers in this situation have to pay close attention to the quality of required data and reporting, as this can guide performance. So that example I gave you of the patient coming in for an X-ray, that data that you collect hopefully impacts performance. Let's say they start getting a lot of complaints that patients are waiting too long. They're not waiting at registration, but they're waiting really long outside in the waiting room of the X-ray department. Somewhere there's a communication breakdown then from either registration to the X-ray department, or once it gets to the X-ray department, to the people in the back that perform the service. So as a manager, in order to improve quality and performance, you're going to have to identify where that breakdown is, or what's happening. Maybe there's a technology issue. Maybe there's something that's not working in the actual X-ray department, some equipment, or maybe they're down staff, or there could be many reasons for that. So it's just a simple example of what a manager's job would be in the performance monitoring and assessment. Then we're going to measure that. And that's the most basic part of quality improvement is the measurement and the metrics that are associated with that. So you're going to translate any observable events into something quantifiable. So all quality improvements efforts require numerical data so that because you can't manage what you can't measure. So what I mentioned in this past example is you're going to do maybe timestamps, where you're going to see what time people come in, what time they register, what time they leave registration, what time they arrive at X-ray, and then how long it takes to have the procedure. So measurement is key to quality, is key to identifying opportunities and issues for quality improvement. And often time is one of the major problems of quality improvement because healthcare is a complex business. If a patient is on the floor and they're sick and they need an IV with a particular antibiotic in it, and they send the order down to the pharmacy, and it takes forever to come back, in the meantime, that patient is not improving. As a matter of fact, they're probably getting worse while they wait for that antibiotic. Today, the process is much more advanced because of the technology. So things like that happen pretty quickly. Many years ago, when I first started in nursing, we didn't have those kinds of things. We actually had, what did they call that system? We had a system where there were, what do we call those? Dumb waiters? Yeah, dumb waiters on the floor. And they went down to the pharmacy department and the supply department, which we used to call SPD. If you needed an antibiotic in a hurry, you sent the order down, and it was it electronic at that point? I'm not sure if it was electronic or not. Oh yeah, that was electronic. I'm sorry. Actually, believe it or not, I was in healthcare when we didn't have computers, and I'm not sure how we survived, but it was electronic when I first got my degree. And we would send the order down, and it would come up on this dumbwaiter into the facility. It would just show up. So as an individual, you had to look for it. You had to remember to go look for it. And there was a bell or something that rang when it arrived, so you would go get it. But it was a kind of an archaic process, but it worked at the time. It worked because nobody had to run back and forth to the pharmacy, or somebody in the pharmacy didn't have to come running up with the. Now they have a whole system where things are delivered and that sort of thing. But anyway, I digress there, but it was a good example of the way things used to be. So you have to measure it. And this way, quality and improvement are driven by data and evidence rather than subjective judgments. Like somebody saying, well, every time I order an antibiotic, when I need it in a hurry, it takes forever to get here. Well, then if we measure it, then we have data that we can prove that. So good measurement begins with a couple things. It begins with a rigorous definition of the concept to be measured. And there's, we're going to talk here about a couple of those things. Where's rigorous? Rigorous definition means the concepts to be measured must be defined in very specific terms. This definition should be written and should include the unit of measure. So you can't measure something that's abstract. It has to be very definitive. But we already talked about wait time. So wait time is an example where careful operational definition is required. It could be defined as the time interval between the arrival of patients at the office and the time they are first seen by the doctor. So we went over that already. So that's specific. And that's exactly what they're talking about as far as rigorous definition. Operational definitions are concrete statements about how to implement terms and procedures in measurement of data collection. So that's the overarching definition of what we want to do. And then method of data collection should also be designed with the analysis. Data analysis requires certain elements to be collected in a specific fashion so that the analyst can compare apples to apples, not apples to tomatoes, which is a whole other topic. The manager needs to, at this point, then needs to know the details of how to design the measurement system, but has to ask the right questions so that they are getting the correct information instead of, well, you understand what it is to define apples to tomatoes. You know, if you ask one person what the the issue is, and then go to somebody else, you're probably going to get two different opinions. So you need to ask many questions so that you drill down to the core problem, not what's happening, but what the core problem, what the underlying issue is that makes this continue to happen or not happen, and you see an opportunity to make something happen. Once you have a good definition of the concept, and the challenge is to measure it reliably. So that means if the measure is taken at several points in time by various people, the measure will generally be consistent. So you don't have to worry, but it says several points in time by various people. So for example, if the person takes the temperature each morning, then it should be close to 98.6, assuming the person isn't ill in the morning. And see, that's the idea. It's a specific time. But then there are other issues that might happen. The thermometer is broken. Somebody takes it, instead of taking it at 7 in the morning, they end up taking it at 9 and they document it as in the morning. Your temperature actually is the highest every day at 4 o'clock. So hence the rule that you can't go back to school until your temperature at the end of the day is normal. I think our doctor used to say, you can't go back to school until the temperature at 4 o'clock is normal for 2 days in a row. That was his rule. That's one of the pieces of data that has to be reliable. If you take it at 7 in the morning and then you report it, that the patient, that they don't have a temperature, but you don't take it again at 4, then it's not a reliable piece of data. So the different people actually measuring the data have to be reliable also, and follow the process. Okay, another challenge to ensure measurement of the concept is it valid? Its validity depends on the accuracy of the measure. So if the measurement isn't accurate multiple times, then it's not valid. That can happen because a piece of equipment isn't working correctly. That could happen because one of those thermometers everybody's taking, the one that touches your forehead, isn't really accurate to start with, or it hasn't been calibrated correctly. So there's a lot of things that go into that. So you can see, when it comes to quality improvement, the process of quality improvement and identifying the factors is very complex. And again, this is part of a manager's responsibility if they have a department that measures that sort of thing. Okay, so let's talk a little bit about continuous quality improvement and improvement projects. Continuous quality improvement creates a continuous flow of process improvements that meet or exceed customer or patient expectations. So we call that continuous quality improvement. And then there are improvement products. So first, we're going to look at continuous quality improvement. And this is on page 147. There are 5 elements of, excuse me, just a second, There are 5 elements of continuous quality improvement. They are a process focus, a customer focus, data-based decisions, employee empowerment, and organizational wide impact. I think this is very important because continuous quality improvement is what you will hear if you are a manager and you go to a hospital departmental meeting. One of the things they're going to talk about pretty much every time you meet, which is sometimes weekly, is continuous quality improvement and where they are. Some of it will be projects, but most of it will be daily continuous reports on that sort of thing. The reason they do that is that continuous quality improvement hopefully results in high quality healthcare. This promotes the view that understanding and addressing the factors that create variation in an administrative or clinical process, which things like we just talked about, longer wait times, high hospital admission rates, will produce superior patient quality and organizational performance. So if we continue to develop the continuous quality improvement process, we should have the result that we will have high quality care and outcomes. It also shouldn't be viewed as a one-time project. Rather, it should be a normal ongoing activity, something that we do all the time. That's process focus. The second element, which is customer focus, is that every effort in the organization must be taken to delight the customer in healthcare, the patient. Improvement methodologies defined a customer in broader terms, and that includes not only just the patients, but it also talks about the physician as a customer, family members are customers, doctors that refer to your facility, they're also customers. So again, the focus of quality also should be the customer. And if you remember in the marketing chapter, we talked about the marketing concept today, which is a more holistic concept. And we talked about we need to be focused not only on the patient, but we also need to look at other stakeholders within the organization, outside of the organization, as well as within the organization. That includes employees, and in this case, all the providers that send patients to your facility. So we're looking at an organized effort to focus on the patient and the stakeholders. So we have this holistic view of the organization as not only a healthcare organization, but as a marketing organization. The third element is data-based decision. And that means we use data to make all improvement decisions. The use of carefully collected data reduces both uncertainty and dependence on uninformed impressions. In other words, it's more objective instead of subjective. And it's hard to argue with data unless the data is the wrong data. And again, that is a manager's job to make sure that the data collected is the correct data and the questions were answered appropriately. The fourth is employee empowerment. I find this very important. It's tough in healthcare organizations, especially it's tough for some of the top management to allow employees to make decisions at certain levels of the process, in the role of the patient care. But today's organizations are getting better and better at that because they have technology that helps support employees in their decision making. And they also have things like their mission, vision, and values that also help employees understand how their decisions should be made and what guides that process. Empowerment suggests that individuals who do the work have a say in improving the work. The typical improvement team consists of employees whose day-to-day work gives them a unique perspective and detailed knowledge of the process being improved. One of the things I learned very early on in my management career was don't make assumptions, go ask the people that work at the front line. make friends with those people. And that includes even the people that clean the floors in the patient rooms or in a doctor's office. They're going to see things that you're not going to see and understand. And until you understand the daily processes of things, you won't be able to solve a problem, because you can't make assumptions and think you know everything. As a manager, it's key, like I mentioned earlier, to work with the team and think of the people that work for you as, well, they're your assets, but they're also they are your best assets. They also are your best source of information, especially since you're not hands-on most of the time. Okay. Okay, members of the team, sometimes if we put a team together to do a quality process improvement, they should be from different areas, any area that's affected for this particular issue. And we have to empower them to actually do the work, give them the decision-making power at a certain level. It's not that they probably won't have the power to order a new MRI, but they would have the power to make changes where they work, and because they probably know what's more effective. And once they identify the problems and start to go through the process and identify how things can be improved, then in an empowerment mindset, they usually are allowed to make decisions that would improve that. They also become advocates for change, and they can help overcome resistance from other employees who might not be real hot on changes. Like we saw in the discussion forum we did a week or so ago about the manager changing how to give medication to infants. So if she had done, like you all said, if she had done a better job of bringing them into the process and helping them identify a better way to do things, they probably would have accepted it much better. And the last thing that's mentioned here, as far as a part of the continuous quality improvement process, is the organization itself and the organization-wide impact that the process has on it. That, again, is accomplished through coordinated and continuous improvement of various operational processes across all organizational levels. So it can't just be in one place. It might come from the top down, but it has to be driven from the bottom up. So otherwise it won't be successful. And again, it has to be organization at all different levels of the organization and organization wide. It has to be a strategic priority for the leadership. That's just no doubt about it. If it's not a strategic priority for them, it's not going to happen, especially in larger organizations. It just gets lost somewhere. Okay, so the last thing I want to mention here in this chapter is that there's a example of the Stewart-Seward-Deming cycle of what they call Focus PDCA framework, which is the most commonly used quality improvement framework in the healthcare industry. It clarifies the steps that need to be done prior to implementation of any process change. And that's on page 148. And it talks about focus. And focus stands for find, organize, clarify, understand, and select. And PDCA stands for plan, do, check, and act, which is more the tactical side. Focus means identifying a process problem, preferably a high pain one. In other words, something that's really affecting patient care. Organize the team, clarify the results. So you can read this yourself, but it gives the management a process to use as part of their strategy in continuous quality improvement. I'm not going to review Six Sigma or Toyota production or any of those things in this chapter. Or tools and things like that. I want you to take a look at that yourself. But what I do want to mention to you is that I posted an article in the units called 10 Healthcare Quality Indicators That You Can't Ignore for the Future. And I urge you to read that because it gives you an idea of what we're looking at in the future for healthcare, particularly in management. Some of them are something we just read, which is similar. The focus is on the patient. employee empowerment, technology, improve the use of technology and how much it's going to change. But there are few in there you probably have not seen before. So it was a very good article. So take a look at that, because as a manager, where you are in your careers right now, where you will be headed, much of that is going to affect you, particularly in the area of data analytics, big data. What's the other one? AI, artificial intelligence, and healthcare. Obviously going to need serious continuous quality improvement, because it's just so different from what we've been doing now. Okay, and briefly in chapter 8 on healthcare health information systems and technologies, I said I was not going to read all about the different types, but I do want you to remember that HIPAA is something that's extremely important when it comes to health education, health information technologies. Is Health Improvement Act that protects your patient data and all patients' data. And when it comes to technology and health information systems, that's a very key driver in keeping your patient information, your patient data private. What was the other thing I wanted to mention? And the Patient Protection Act. There were two things in the beginning of the chapter that I wanted to make sure you paid specific attention to. And then on page 175, again, we see healthcare information technology moving forward. So the article was about quality improvement, and this is healthcare information. It gives you a background of how many people were using electronic healthcare records and how many is now. So clearly that's the direction that all healthcare providers will be. There are still some outliers now that won't do that, that aren't doing it, but they're in a couple of years, or it might not be that long from now, the the MUSE system, Meaningful Use Act, requires them to be on electronic health records, or they won't be paid by Medicare. So many of those who are still reluctant to jump in the pool are going to have to at some point in the near future. Moving forward for health information technology, the text lists a number of things. Interoperability, which is the ability of different information technology systems and software applications to communicate. Clearly an issue in many facilities. I worked on an electronic health record for HIV and AIDS a number of years ago for a pharmaceutical company who was developing an electronic health record specific to that disease process. The federal government requires that HIV clinics collect many pieces of data and report it back to them in order for them to get the funding that is available to them from the federal government to take care of people with HIV and AIDS. Unfortunately, the interoperability of these disparate systems really affected how these clinics could operate and drove up their cost of care, because they literally had to have people manually entering data sent on a written report to the government about their care. So this electronic health record I worked on was a solution to that problem. The issue was, how would they connect it to the government system? Because the government system was basically archaic, and the electronic health record I was working on obviously was up to date. So it was a challenge. I'm not even sure they ever got it off the ground before I went to work somewhere else. But interoperability is a big challenge. And until they can get that straightened out, healthcare information systems is going to be stuck here and there. Optimizing and replacing electronic health records, like I mentioned about the MUSE laws, that's going to change. Data integrity, something we always used to say when I worked, and it's in the text, garbage in, garbage out. If you put in the wrong data, you're going to get the wrong data out, and it's not going to help you. That's something that everyone has to get more efficient and effective at. Safety is a big issue for patients these days. That's going to continue to be. Cybersecurity, your data, your parents' data, everybody's healthcare data. You know, if you're using a healthcare app on your phone or your Fitbit or whatever, and you're sharing that data with them, if you're not careful, they can share your data with somebody else. So it's up to you in some cases to keep your healthcare data private. You don't always want your employer to find out about your healthcare data or whether or not you're going to see a psychologist because you're having issues. You know, that there's some very important things there. And in order to keep that private, you have a part, as well as so do electronic health records, and not sharing it with and how they're going to keep that secure. Cloud-based systems is another challenge. They talk about passive and active use of an electronic health record. Active use means that using the data from the electronic health record and the patient in real time in conjunction with decision support tools and that sort of thing. Let's see, what do they say that passive use is? Oh, passive use is just reviewing data for other healthcare providers. Then you need to look at e-health, which is communication technologies, what they call ICT. Three main areas: delivery of health information, use of power of IT and e-commerce, and e-commerce and e-business practices in health systems management. Again, disparate type businesses, disparate type programs that need to be coordinated. And then mobile technology, I mentioned that earlier. Telemedicine and telehealth, health informatics, which is the use of information systems and technology to redesign, improve, and create disciplines such as practice of medicine, nursing, so how they use that data. And then analytics and big data, which is a big focus. And that's some place that you might be able to go as a healthcare manager. So what's the impact of information technology on the healthcare manager? This is on page 180. Managers need to have the competencies to effectively evaluate the experience of their staff in the use of required systems, their own ability to quickly adapt to new tools, and to manage their workload, their interactions with third-party vendors, offering external stuff, and cloud-based information systems for security. So it's important that a healthcare manager understand these kinds of things because of our health information systems. Technology also has given a rise to new types of employees, such as medical scribes who assist physicians. I've seen a lot of those in doctors' offices recently. And they enter the data into electronic health records. And again, that's something that has to be really carefully monitored, because if it's not correct, you have a healthcare scribe that's not at a physician level and they don't quite understand, there's could be a lot of communication issues there. So that's very key. And as healthcare manager, you have to look and determine whether or not if you use these physicians, it'll actually increase efficiency and effectiveness. So in regards to healthcare managers, your job when it comes to continuous quality improvement and health information systems is a big one. And it's complicated, but you can be guaranteed that this topic will be a part of pretty much any position you take. And you will never stop hearing about it. It will always be something that's part of your job. So that's my lecture for today. Thank you very much for your time. I appreciate that you actually watch the lectures. Again, if you have any questions you need to ask of me regarding the lecture or the assignments or the group project, please be sure to do that in either the Ask the Instructor form or send me an email. Sometimes it's best to send me a text and say, hey, I have a question, and I send it to you in an email or whatever, if you want an answer quickly. And I'll do my best to do that also. So I don't have any problem with you sending me a text. All right, everyone, have a good week, and I'll see you in the forum about Mrs. Bell. Thanks very much.